So a little bit more physics to support some of the Doppler slides that Ellen Mendelsohn showed before the coffee break. This Doppler technique that the scanners use employs something that you probably learnt about at school, which is the Doppler principle. And that's illustrated in this diagram that is in many textbooks, which shows that if a sound wave is traveling at some speed, c, in this direction, and interacts with a small ultrasound scatterer, and that small scatterer will send out the scattered energy in all directions. Then if you are an observer standing over here, you will detect scattered waves arriving at a rate that we see here between these wavefronts. And that will be the frequency that you perceive. If you are standing over here, in other words, a receiving transducer here, then you will perceive waves arriving again at the same rate, and the same for the sound scattered backwards. So it doesn't matter where you are, you will perceive the sound arriving with wavefronts at the same rate. So the frequency that you detect is the same in all directions for this stationary scatterer. But if the scatterer is moving, in this case with a velocity v, away from the source direction, or in this case with velocity v towards the source direction, things change. And they change because the scatterer is actually in different positions when it emits the scattered wavefront. When it was here at the original source location at some early time, it will have emitted this wavefront, the outer one. And then in this case, it's moving towards the source of sound. And so it will be in a new position here when it emits this wavefront, and a new position here when it emits this one. And you can see then that it now depends on where you are as an observer or as a receiving transducer. If the receiving transducer is over here, then the rate of arrival of these wavefronts is slower. You can see the distance between the wavefronts is larger than it was here. So you would perceive a lower frequency or rate of arrival of wavefronts for this moving scatterer when the scatterer is moving towards the sound. If you are on this side and you're receiving backscattered sound, then the scatterer is moving towards you and you perceive a higher rate of arrival of the wavefronts than in the stationary case. And that's a higher frequency. The difference between this frequency and this one is what we call the Doppler shift frequency. And it depends on the speed of the scatterer. Let's reverse the situation, and the whole diagram reverses. And the scatterer is now moving away from the source of sound. And now, if you are receiving sound that's scattered back to the source, as we do in ultrasound imaging, now you will perceive a frequency that's lower than in the stationary case. So scatterers that move away from the transducer produce a negative Doppler shift. Scatterers that move towards the transducer produce a positive Doppler shift, an increase in frequency. And it's as simple as that. The scanner processing has to do that job of detecting what the difference is between the frequency of the sound that's put in, which is the same as the frequency of the sound that's scattered from stationary scatterers, and the frequency when the scatterer is moving. It does depend on that angle, though, and you'll notice that if you are standing over here, and you can see the rate of arrival, the distance between these wavefronts, up to a point about there, but this distance is actually the same. The rate of arrival is the same as it was in the stationary case. So the 90-degree observation point, when the direction of motion is exactly at 90 degrees to the observation direction, there is no Doppler shift. And it's in proportion, in fact, the cosine of the angle. Now, this means that if the movement is due to blood flow along a direction of a blood vessel, the angle between the blood vessel and the direction of the sound beam is very important. So you will get no Doppler shift if the blood vessel and the sound beam form an angle of 90 degrees, and you will get a maximum Doppler shift if the blood vessel is along the sound beam. And at other angles, it's in proportion of the cosine of the angle. The other factors in this Doppler shift equation, the Doppler shift being the difference between the frequency that's transmitted into the body and the frequency of the sound reflected by the moving scatterers. The moving scatterers in the blood are red blood cells, the erythrocytes, predominantly. That's the Doppler shift, the difference between those frequencies. It's determined by the cosine of that angle, the frequency of the sound that was originally transmitted, the velocity of the flow, and there's a factor of 2 here because there are 2 Doppler shifts. One Doppler shift because the red blood cells are acting as moving receivers, and then another Doppler shift because they're acting as moving reflectors. So that doubles the Doppler shift. And then the speed of sound in the background medium is also in the denominator here. Things that you have control over are really the transmitted frequency only, and possibly the angle of the sound beam. You could angle your transducer to try and increase the Doppler shift and get a better measurement sometimes. You can steer the sound beam, the sort of steering that's used in the scanner for the compounding that we discussed earlier before the break, can be used here to steer the sound beam to make that angle smaller and make this a more favorable situation. So understanding, once again, understanding a little bit of the physics can help you get a better result. And we'll talk a little bit more about that in the coming slides. The history of the subject is quite old, and it goes back to the late 70s and so on. But the person who first thought of using Doppler for breast cancer diagnosis was Peter Wells, who unfortunately died about 2 years ago. And in 1979, he suggested, based on the work of Judah Folkman, who was the first to identify the importance of vascularity in cancer, and then a whole lot of others looked into it, and research on the subject is largely over now, and it's into routine use I would say, in a fairly small way. Alan Mendelsohn mentioned earlier that a problem with vascularity, it is not particularly specific, but it can add to your confidence in the diagnosis. Why does it do that? Well, it's important in the whole area, a number of different areas of nutrients, oxygenation, routes for metastatic spread, drug access, thermal regulation, interstitial pressure, angiogenesis from a biological level, and they translate into a whole range of application areas of importance that I won't bother to read out. That detection of the difference between those two frequencies, the frequency that's transmitted into the body and the frequency of the Doppler shifted sound from the moving red blood cells, the machine does that by extracting, it's a very small difference frequency that you see. This is the F0, the transmitted frequency. This is the Doppler shifted version. And what the machine needs to do is take that all the way back to here so that you just end up with a small difference. You remember that our transmitted frequency is in the region of megahertz, and the blood flows so slowly that it only shifts the frequency by a few kilohertz, now, or even hundreds of hertz. The nice thing is that difference is a few hundred or kilohertz. That's in the audio range. Once you've done this shifting and you've detected that difference, and diagrammatically it looks like this, this is the transmitted frequency and this is the received frequency. The difference between these is a very slowly varying wave. But you can play that through a loudspeaker or through headphones, and it's audible. And that's the nice thing about it. It's a pure coincidence of nature that the frequencies of sound that we use for imaging, subtracted from the shifted frequencies due to the typical blood flow velocities, it's just coincidence that it ends up being audio frequency, but it's very useful. In the early days of this, we did what we call continuous wave Doppler, which is actually what was illustrated on this slide. It's when we don't pulse the sound, we just send out a continuous wave that's just there transmitting always. And that means we have no resolution down the beam axis because there are no short pulses. We only have resolution of the sound beam in its width, and we can focus it if we wish for lateral resolution, but we have no axial resolution. This means then if the scatter is moving along the sound beam like that, we can hear the Doppler shift all the time. And that sort of probe that we use for that, you can actually explore the breast. You can make spectra of the time-varying Doppler signal. This is time. This axis is frequency. And the vertical axis is strength of the signal. And typically in breast tumours, we would see signals like this. This is back in 1981 when we were experimenting with the technique. And this corresponded to very small vessels, very high frequencies, low vascular impedance causing in diastole. You can see the systolic pulse and diastolic waveform here as you go through different heartbeat cycles. And it persists in diastole in the case of a breast tumour, and you have this complex distribution of frequencies corresponding to beams that overlap lots of microvessels with continuous flow. And you get a much more pulsatile result in the case of some of the benign tumours where the vessels are behaving normally. You can also map out, a lot of time was being spent in these early days exploring the vascular network patterns and showing that in a single patient, the vascular pattern that you could map out if you took the time to do it was very symmetrical on both sides. So on the contralateral breast, you could often use that as a control to compare the vascular pattern with the suspected breast. And that was thought to be a useful technique. In a busy clinic these days, a lot of these ideas have tended to be lost. So I'm sort of describing some of the history of the subject to you so that maybe you can think about it for what you want to do. Some of the other work that was done early on was looking at how in a series of tumours, how tumour volume influenced the result of the Doppler shift frequency. So if you start to average the frequencies that you see in these spectra, or the ones that you hear when you're listening to it, and then divide that by the tumour volume that's on this axis, you end up with this graph, which actually is the graph that you would predict, and the prediction is shown with that solid line. So it's a pretty good fit. And that prediction is based on a model that is only a sphere of a given diameter that corresponds to the tumour volume. And a model just assumes that the vasculature is only distributed on the surface of the sphere, as if it was just centered around the vascular rim of the tumour. And look how good a fit it is, suggesting that in this series of breast tumours, that most of the vasculature was concentrated around the rim of the tumour, which is not surprising because that's the advancing, growing edge of the tumour. It needs the blood supply. That's where all the cancer cells are rapidly multiplying as it invades the local tissue. Also, another phenomenon in premenopausal women, if you look at the normal breast, you can see how much the blood flow, this is both velocity, if you go back to these signals, if you combine how high the frequency is as well as how strong the signals, you end up with something that we used to call as a relative flow index. And as a function of time in days, with menstruation being indicated here, here, and here, you can see how much this fluctuates. And I won't show you the data, but I'll just tell you that that fluctuation is actually bigger than the difference between the vasculature in a typical tumour and the surrounding breast. And it's another reason for wanting to use the contralateral breast as a control, because typically you see this pattern being maintained in both sides, the left and right breast. And by using the contralateral breast as a control in a premenopausal woman, you can take out some of this cyclic variation from corrupting your interpretation. And then response to treatment. At a time when tamoxifen and drugs like aminoglutamide were being tried, this is very old work, but nevertheless it shows some ideas we had about monitoring response. And we tried using Doppler to see whether it would pick up changes in vasculature earlier than when tumour volume starts to change, to see if it would work. And although we found that the two correlated very well, generally speaking, there was very little evidence that it changed in advance of tumour volume. So that was a bit of a disappointment, but nevertheless it's worth knowing that it can also be used. Those were the days when Doppler was that continuous wave Doppler, this indicated here, when short pulses were not used. When you start to use short pulses, you can start to detect where in depth the signal is coming from, just as we can with ultrasound imaging. And that starts to allow you to make images, 2D images and 3D images of Doppler. And that's why we can get images such as this in, for example, the carotid artery. And now the systems allow you to direct one sound beam along a line of sight and control and steer the sound beam to try and improve that Doppler angle, and also indicate to the computer on the screen what the direction is of the blood vessel in order to calculate a result that is estimating the speed of blood flow in centimetres per second. And you can adjust that to see a spectrum here. But also the system allows you to display a full image where what's happening at each pixel in the image, this whole trace is being analysed as a function of time, and a mean frequency, mean Doppler shift frequency is being extracted from this spectrum at that pixel, at that time, and then placed on. The same thing is done in all pixels, placed on the screen as a full image, color-coded, where red and blue here represent flow towards or away from the transducer. You can easily reverse these directions, but there will be a minimum blood flow velocity that you can display. And as Ellen said before the break, you need to be careful to set the pulse repetition frequency, because that pulse repetition frequency defines what that minimum displayable velocity would be, and also the maximum displayable velocity before you get artifacts in the image. And if there's time in the hands-on session, if you want me to explain that and demonstrate it, I can certainly do so. But please, there's a lot to do in the hands-on session, so if you are interested in this, do tap me on the shoulder and say, please explain the Doppler. Otherwise, we might not get time to do it. So Doppler is quite a complex subject, but most of the time, you would be not using the spectral Doppler. You'd probably use just the color flow imaging mode, because that's the fastest mode to use. to do colour flow imaging, the machine has to do a number of things. It has to take a lot of very complex information, time varying, frequency varying, and strength of the signal varying. And it has to turn all of that information into a single value to put onto the screen. And it does that by making certain decisions. And if you're not aware that it's making those decisions, and sometimes it can get those decisions wrong, then you won't be aware that the image you're looking at has to be interpreted with some caution. And that caution is that there will be missing information and incorrectly displayed information. And I'll just talk for a few minutes about that. So that display logic in the machine decides when to display flow information and when to display anatomical information. Typically, low velocity combined with high backscatter signal strength indicates anatomy, because solid tissues, rather than red blood cells, send back stronger echoes, and solid tissues are not moving. Not much anyway, there's breathing motion and so on. So the blood, tiny red blood cells, scatter little, so the signals are very weak, and the blood is moving, and so it has higher velocity than the surrounding tissue. Those are the two things that the scanner uses when it decides what to display, the B-scan or the colour flow information. And by doing that, it can display these types of images. And I've shown these two images in a very large blood vessel that's curving around for illustration of one point here, which shows that you get a change of colour from one direction to the other. And you get that point where the sound beam is at 90 degrees to the flow direction when the Doppler shift is not high enough. Strictly speaking, it's 0 at that point, and that's what we're seeing on this display. It passes through flow towards the transducer in red, through 0, and flow away from the transducer, sorry, blue I should have said, I'm going colorblind, towards the transducer and away from the transducer in red. And that illustrates how arbitrary that scale is. There's a user controller, you can flip the direction if you wish, and turn this to blue and this to red. Over here, you see a strange situation where the color is changing even though the flow direction is still always away from the transducer. And the reason for that is that the pulse repetition frequency is set too low, and the flow is being undersampled. I have to say those words. I know you don't know exactly what they mean. It would take a longer lecture to explain them. But something that's called aliasing is going on here. My easiest way to describe it is that if you ever see those old movies, the black and white movies like Casablanca, do you remember when Humphrey Bogart was on the runway in Casablanca? I hope I'm talking about a movie you know. And the aeroplane is, and it has the propeller on the old-fashioned aeroplane. And those cameras had a very low sampling rate. The frame rate was very low. And as the pilot starts the engine, you see the propeller rotating in the correct direction. But then as the propeller gets faster, at one point it stops, and then it gets faster still, and it starts to go backwards. That's the effect here, is that the flow is being undersampled by the pulse repetition rate of the ultrasound. If that analogy helps, then good. So actually, though, for radiological applications, if you're only interested in how big the vessels are, which direction, what the pattern of the vasculature is, then possibly you don't mind that it's aliasing. Here are some examples of the patterns of vasculature in real breast tumours. These were actually taken with the very first Doppler, color Doppler system that Acuson, a company in the now that doesn't exist, Siemens bought them. and illustrate some really sort of malignant-looking patterns with strongly penetrating vessels, in this case into a tumour, the boundaries of which are way outside the image, and in this case the boundaries of which you can see here clearly. But those are very malignant-looking patterns because of the very high blood flow velocities that you see, the aliasing, the flow is so fast that it's aliasing, and it's penetrating into the tumour rather than being purely around the rim. There are two types of display, the power Doppler display and the colour velocity Doppler display, and I've only been showing you this one so far. I've shown renal examples here because they illustrate it so beautifully, even though there are some examples of breast tumours here. Using the renal examples, you can see the renal vasculature and the tree nature of it displayed nicely. You can see in the velocity-based images where the pixel values are proportional to the mean velocity in the Doppler spectrum. You can see how the aliasing causes the flow velocity to change direction apparently as you move further and further down the vascular tree. And that's because the flow is so fast it's being undersampled in the larger vessels, and further down the vascular tree where the flow velocity decreases, it's being correctly sampled. With the power Doppler, instead of displaying mean frequency, now the power displays the mean energy in the signal. And the mean energy is the same regardless of which direction the flow is. Therefore, you don't get any effect of aliasing. And if what you're interested in is purely vascular anatomy, then this is the better display mode to use. As you can see, it gives a clear display of vascular anatomy without the effect of, maybe distracting effect of the aliasing. And that's sort of, those differences are illustrated in these slides, which I'll go over quite quickly later. If you wish to look at the slides on the online version of the lecture, you can think about these points. But they're illustrated with a single vessel, hypothetical vessel that passes through the sound beam that is supposed to have exactly the same flow properties all the way along it. And the only thing that's changing is the flow direction as it goes through this curved path. And at this point, the flow direction is mostly along the sound beam, and at this point, it's almost at 90 degrees. So the Doppler spectrum, frequency here and power in the signal, would be the same, except that it shifts to a very low value, in this case, where the angle is nearly zero, and a very high value when the angle is nearly at 180 or 90 degree, 0 degrees. Sorry, that's 90 degrees for this one. So we get a mean frequency here that is related to the flow velocity, but only related because it depends so much on the angle. You get directional information, and this value is largely independent of attenuation. So you don't need a time gain compensation or swept gain for this type of velocity imaging. But what you do have is a kind of color noise. If this signal were very low and not very strong, then you would find that the scanner trying to calculate that mean frequency to display on the color Doppler image to put on here would find it very difficult to estimate that. And the result could appear anywhere along this frequency axis. This means that for this type of image, the color noise is very distracting. And usually you set a noise limiter to exclude it entirely, because otherwise it's distracting because it's like a firework display of anywhere across this axis. Overall, these images, you have to be aware that these images are not quantitative, and that's because of the angle dependence. And also, when the flow is nearly at 90 degrees, you'll have missing information. So all of those things are worth bearing in mind. For the other one, for the power Doppler, you have these features. What you're calculating is the area under this spectrum. And that doesn't matter what position you are on here. It's independent of the angle. What you're putting on the screen is something that is related to blood volume. It's not related to velocity. So it's kind of a blood volume image, is this image. And there's no directional information. It does require depth correction. You need a TGC or swept gain for this. And the noise occupies a fixed low level. It's a very nice image to look at. It's more complete than the velocity image because it doesn't have that angle dependence, but it's still not quantitative because the signal attenuates with depth and it depends on other factors, and it still has missing information because of information. You get images such as these, and there are various diagnostic criteria that you can apply that I've already been describing, whether it's external or marginal, whether it's internal, radial and penetrating, and so on. Bill Svensson, way back in the late 90s, did a big study on this, I'm getting short of time, but just to summarize that, he found that it could add, essentially, as I've already said, could add confidence, but be careful. It's not a particularly specific technique. It needs to be used in combination with your B mode criteria, which should always remain of higher priority in your diagnostic decision making. One thing that we did a long time ago was quantify these properties, and we wrote software to do that. And something I keep meaning to return to in a research context is to see whether these sorts of results can be maintained. But when you start to combine Doppler features in a quantitative way, they can give you very good discrimination, at least in this small sample of 74 tumours, a complete discrimination between fibroadenomas and carcinomas. So although at the moment with subjective diagnosis, it isn't very specific, there was a bit of evidence years ago that we could do better. One of the ways of doing better is to use contrast agents, and that's still a research topic. Contrast agents, microbubbles, change their size in different parts of the wave cycle to a large extent because they're filled with gas that's easily compressible. And they send back a very strong echo for that reason, much, much stronger than red blood cells. So it's a way of improving depth of penetration and improving signal strength, but also a way of uniquely identifying flow in the vessel rather than using the Doppler shift, using harmonic imaging. With Doppler and with harmonic imaging, you can see these agents wash into the tumour, reaching a peak at about 1 minute after injection and wash out over a few minutes. And you can plot time intensity curves and measure arrival time, time to peak, area under the curve, the washout time, the transit time, various things like that, that are all related to sub-resolvable characteristics of the vascular pattern. And so, in principle, you can get diagnostic features from this. But a whole series of investigators in a research context have had contradictory results on this subject. And so it hasn't really got into mainstream use. Broadly speaking, you can draw some conclusions from this research data. You can say cancers relative to benign tumours tend to have more enhancement, abnormal architecture, earlier and longer enhancement. Earlier, the flow flows in quicker, but lots of opportunities due to tortuous vasculature and blind-ending capillaries in malignant tumours for that enhancement to be maintained as the contrast agents are trapped a bit longer in the tumours than in benign lesions. but still not very specific. Harmonic imaging in combination with contrast agents can give you beautiful images. There are multiple ways of using them, and in this large liver metastasis, simply because it illustrates it so beautifully. If you inject a bolus of contrast agents, you can see it wash in and wash out, and this shows the image as a function of time repeated in this movie and sped up over, it's actually happening over minutes, or during the arrival, you can actually burst the bubbles in the imaging plane and watch a destroy refill a few times, and then you can see this wash-in phase multiple times compared to just watching the whole bolus, which is happening over a longer time period, over many minutes. And you can accumulate data over one of these bolus injections with what's called a maximum intensity projection image and get a beautiful picture of the microvasculature in this sort of pattern. Not much of that is done in breast tumours. There's still plenty of scope for work in this area and further research. The most recent sort of techniques in doing this for breast tumours using contrast harmonic imaging uses this improved microvascular sensitivity compared to relying on Doppler signal alone. There's general agreement that malignant lesions show early wash-in, more intense enhancement, and faster wash-out for these. It somewhat contradicts the earlier research, so more work is needed to really figure this out. There's still no observer agreement regarding vascularization patterns, I think. And although there are individual experts around the world and individual enthusiasts in the broader context, I think we would have to advise you that this is something that's still very difficult to use. The direction of some of the research is actually now moving towards taking these time intensity curve parameters and doing this at individual pixels in the image, and then making what's known as parametric images. And this mirrors, to some extent, what's done with what's called DCE-MRI, dynamic contrast enhanced MRI. And this is essentially DCE ultrasound for breast tumours. And there are only a few research papers illustrating this and showing that there's some potential for diagnostic improvement. This is with these features only, not being combined with the B-mode imaging features, achieving reasonable specificities, sensitivities, and combined accuracies. More work to be done. So it could be you that does the research work and adds to this data, and maybe one day we'll know how to use it better. And I think that's pretty much all I wanted to say, except to warn you that there are some artifacts. They're easy to identify. Calcifications can give Doppler signals because they are vibrated in the sound field, and that makes them generate a Doppler shift. The sound exerts an acoustic pressure on them and actually causes them to vibrate and generate a Doppler shift. But you can easily identify that artifact because it's in the direction of the steering. And if you change the steering direction, you can make that color Doppler artifact actually go in a different direction, which wouldn't happen with real blood flow. So that's just to warn you of that artifact that is easily discriminated. Thank you.